I will call or invite Dr. Professor Craig Anderson for his next talk.
So good afternoon everybody, and I'd just like to thank the organisers again for allowing me this opportunity to talk to you. I was given a very general talk which was stroke issues in the developing world, and coming from the developed world, it's always a challenge to suggest suggest solutions in the developing world. It's better that you find the solutions yourself and learn from the West and adapt them to find solutions that are practical within your context. And I thought that where I could help is to give you some advice around doing clinical research, because if you have to find solutions for your population, you need to evaluate and to understand what works and what doesn't work, and therefore you need to have some ability to understand science, and also you need to understand the medical literature. If you read articles in Lancet or New England Journal, you have to understand how science is communicated. And also, some of you in your career may have the opportunity to do clinical research to get top jobs or to get promotion, and so maybe in my talk there can be some inspiration for you to consider having some opportunity to do clinical research in your career, because it can be very infectious. I mean, it can be like a drug that can give you the passion to want to do more and more clinical research in your heart. But doing research is challenging. It's very challenging. That's why not many people do research, not just in Pakistan, but all around the world. To graduate in medicine and to do research, maybe less than 5% of people ever do any research, because it's hard work. And also you have to have the mind to do research. If your mind is very changeable, very hard to do research. To do research, you have to be able to think, you have to be able to pursue a problem for a long time and be patient and have a clear mind. And that is why I always think that hospitals and university who encourage research will encourage good doctors, because good doctors can think, they can make sense, and they can make clear decisions, they can make sense of things with a clear mind. So doing research is good, but it is challenging. And it is also wasteful, because doing research and getting a good result and getting it published is hard work. And this was highlighted by Sir Ian Chalmers, who is one of the founders of the Cochrane collaboration. And the Cochrane collaboration, the Cochrane Library, is to gather all of the highest quality research, generally randomised controlled trials, to work out what is good treatment and what is bad treatment or harmful treatment. And he did this review which highlighted the waste in medical research. And the waste is because the questions aren't really very useful questions, or that the design is a poor design, or that the publication either doesn't get published, and that is a tragedy of research. If you get some funding and some money to do research and you actually ask the patient to give you some of their data and it never gets published, you never present it, that is a great tragedy. But if it gets published and it gets published in a very obscure journal, no one ever reads it, then it is not very useful. And then finally, is the research reliable? And there are many problems. So they estimated most research is very meaningless. But don't feel too bad here, because as people we are wasteful. We waste food, we waste time, we waste politicians waste money. We're not perfect. So medical research is also not perfect, but we can be more efficient to do good research. So what are the barriers? Well, you cannot do good research without money, unfortunately, or resources. So obviously we need to find some money. There's never enough time. And one of the big problems in developing worlds, and I'm sure it's a big problem here, is we're just too busy. Doctors are just too busy doing the work and too busy with life, and never enough time to protect ourselves, to think. As a student, you can think and study, but once you go out into the workforce, you have to make a living, earn some money, and work long hours. To do research takes time. You can do some quick research, but generally quick research is not very useful. If you want to do good research, you have to be patient. You have to write a protocol. You have to get ethics approval, because if you study patients, they have to give you their consent, and you need ethics approval, and often you need some training. Not all patients are easily to find, and they may not be willing to take part in your research, but it appears that Pakistan people are very obliging to the community. You have a very good culture of wanting to give back and to participate. So recruitment here is very high. If you're doing a big data, you need to do the statistical analysis, and then finally you've got your data, you've looked at the analysis, you have to write it and get it published. And if you're from a non-English speaking background and you have to try to get your paper in an English journal, that is very challenging. And English is the language of science, and therefore you should always strive or to work with somebody who can help you to write with good English. So where would be the opportunities for you here in Pakistan to do some research? Well, one of the big issues is you have lots and lots of patients. You have lots of patients with disease. You have lots of patients who are at high risk of disease. And you have lots of patients with uncommon or rare diseases, which people in the West will be interested to know about. You can do your research here at relatively lower cost compared to the West in all aspects, not just the salary of your salary level, but also the whole costs of the data collection, which is quite attractive. But we have to be careful that lower cost does not mean lower quality. It means lower cost but good quality. Also, it's imperative. It's imperative because your health, the health of your population is changing. You have big problems of non-communicable diseases and injury. Your demography is changing. Like in all other countries, it's changing very quickly. You're getting old, you're getting fatter, you're getting more cardiovascular risk. You're moving from the country to the cities. You're getting urban poor as well as country poor. You have problems with children. You have problems with pregnant women, you have problems with older women, you have problems with care of dementia. You have big problems, and you need to find solutions relevant to your population. It's a public health imperative, and clinicians are leaders. You are leaders in your community, and you are leaders for politicians, so that you have a role to play, not just in clinical practice, but in influencing public health. And if you can find solutions here, and we've had some very nice talks this morning, I'm very impressed by your e-health program. If you can find some good results here, it could be generalisable or widely applicable to many other low to middle income countries within the Asian region. It's also, research is very good to attract international cooperation and engagement, and it's also very good to progress your training and learning opportunities by doing that. So I always think about research as a life cycle, a timeline, and when I have managed randomised controlled trials international, the timelines go over many years. But all projects have a phase, a start-up phase, a maintenance phase, and a close-out phase. The beginning, you have to try to get you have to think about your design, you have to get the money, you write some applications, you get your money, you have to train the staff, get ethics approval, regulation, you've got to get going, you've got to assess the patients. If they're staying with you for a period of time, they've got to come back to the clinic. You have to monitor their adherence to the protocol, any outcomes, and then towards the end you've got to close up, analyse all the data, write it and get the publication out. And this may be 1 year, 3 years, sometimes even 10 years to do all of this. And then ultimately, for all researchers' goal is try to get it into the top journals. We always want to be international and top journals, but not everybody obviously can get into the top journals, but you should aim to get it in important journal, not just within neurology, but within Pakistan, but maybe somewhere else in an international journal. So how can we measure the quality? Thinking about your research, what is the quality? Because high quality guarantee publication. Low quality, always harder. You know, good research just starts with a good question. Think carefully about what is the question you're wanting to solve. And then once you've got the question, it's thinking about what's the best design that I can put to answer the question. First, think of the question. Second, think of the design. Obviously, doing the study, thinking of the design, conducting the study, you have to make sure that there's no error. You know, studying people is very hard. You know, we don't take our pills, we get grumpy, we lie, our body changes. You know, it's quite hard. It's not like a rat in a cage where we can control everything, the food, the activity, the environment. Studying people is hard. And our tools to do it, to measure health, the tools to measure health are not reliable. And then finally we have to write with a skill. Writing is a skill. So let me just take each of these a little bit further. What is a good question? Well, obviously a good question is no one has thought about it before. You know, this is a good thing. Getting a mobile phone. Bottled water. You know, who thought of bottled water? They're multi-millionaires. I don't know if you get Red Bull, the energy drink in Pakistan. You know, that is a multi-million-dollar company now, billions. If you have a good idea, it's really good. You'll get a Nobel Prize, but not everybody can think like that. Another question is, if you think of the question, it's simple. You know, we make our questions too complicated. It's one of our human faults, is we always think too much. Make the question simple. How can this question be relevant? And obviously, if you have a question, you have to have a good justification for the question. So you've got to do a bit of research for your research question. Read the literature and quantify. Sometimes we have to quantify the question with meta-analysis. It's got to have biological rationale, but you can come up with any story around biological rationale. You've done pathology, you know the biochemistry, you know anything's possible in the human body. But it's got to have a reasonable plausibility. And obviously if it has a large health impact, that's going to be good both from a health point of view or business point of view. And when I have a question, I have to go out and talk to doctors. And if the doctors don't think it's a good question, they won't cooperate with me. So just sitting in the university, or you know what's called sitting in your ivory tower, thinking up all these great things, if you can't go down and talk to other people and convince them that this is a good question, if they've got to recruit patients for you, then it's not a good question. And then finally, it has to be feasible, realistically. How much time do you have? How much money do you have? Really, what's possible? And what is your strategy to be able to do that are all very important when you're thinking your study. So, that is right. Most of the research we do is confirmatory. We are followers. We are following. And it's best to be near the front, always in life. Be near the front. Don't be right at the back. So most of us doing research, we're just coming up a little bit behind the first person. But that's okay, because most research needs confirmation. It's very rare that you'll get one study that gives you all the answers. So, you have to think, what's something a little different? If somebody has found something, what can I do that can add value? Maybe different type of patient, maybe older, younger, sicker. Maybe we look at it in a different type of setting. Maybe we go a bit longer. Maybe we start earlier. Is there something different? Always think of something different. If you just repeat the same study, the journal thinks, oh, it's old news. Medical journals are like the newspaper. They want to have a headline. They want to have news, something different. If you're thinking the research question, and I hope the students have been taught this in epidemiology, use the acronym PICO, or PICOT. P is for the population, define your population, the patients. The I is for what is the intervention or the exposure, control, what is the comparison, what is the outcome, and what is the time frame. Always think of the PICO. Because the PICO, again, when you're thinking about research, you have to organise your thinking into some structure, and it will guide you on how you want to design your study. So, what are the research questions? Most research is descriptive. We are describing something. And or analytical. So incidence, prevalence, you just go out and you count. Maybe you want to evaluate some diagnostic accuracy. You compare something in terms of a gold standard or compare it to something else. Prognosis is very common in hospital practice. We have patients and we want to prognosticate their recovery or their risk of dying or something else. And then there's the intervention studies, which is randomised controlled trial. So what is a strong design? Well, randomised controlled trials are the highest quality because that is where we get the least biased evidence. That's what's relevant to clinical practice, and that's what the guidelines use. And randomised controlled trials, you just got to make sure that they are good quality, because that's the foundation of our clinical practice. I've used this as a picture to try to describe something. So basically, when you do a clinical trial, or actually when you do any research, we're interested in the effect or the association. It's a nose. It's a small effect. Most of risk and most treatments in medicine, they're very small effects. Cure is, if in surgery we can get a cure, infectious diseases we can get a cure, but in chronic disease, our treatments are very small. They're modest. And we have to determine this small effect across others. And again, for the medical students here, is the three factors that you always have to overcome in research is chance, confounding, bias. Chance is just bad luck. The only way to overcome bad luck in research is large numbers. If you study 10 patients, you get a lot of chance association. 200, less likely. 2,000, very minimal. Just more patients, less problems of random error, chance. Confounding is other factors, and I'll just show you a thing about confounding. And bias is just measurement error. It's the measurement, the tools we have, or some other factor. Always, we want to get a true effect or true association across those things. So confounding, it's a big problem in all our research. In all we do is confounding. So if we're studying, for example, a risk factor, hypertension, or an antihypertensive with a particular outcome, we want to examine, does hypertension cause heart attacks? Or does our drug to lower blood pressure prevent heart attacks? That's our goal. An association, a treatment association or a risk association. But there are confounded. Obviously, age is related to heart attack. There's a difference between males and females. There's obviously smoking is related to heart attack, BMI and weight, waist circumference, cholesterol, the baseline level of blood pressure, other factors. These are confounders. So when we do a randomised trial, we can balance these confounders. When we do an observational study, we have to measure these things to control for this association. So we have to record them. But the problem is there are other things that we haven't measured. Maybe we just haven't got enough data to collect. And also there are some things we don't even know about that could influence the association. And that is what's called residual confounding. Residual confounding. So in any observational study, we want to look at these patients, whether they have an outcome here or an outcome here. We always have the problem of confounding, and we can never fully control for these confounders. We find an association, is it true or not? There's confounding. So randomisation balances out the treatment and it balances out the confounding. And that's why randomised controlled trials is the highest grade of evidence, is it controls for the confounders so that we can determine that individual factor and its relationship to the disease of outcome. But even with clinical trials, there are a number of factors that we have to have a look at to make sure, even with a randomised controlled trial, it is of good quality. So even though randomised controlled trials are the highest level of quality of our research, they do have a problem. And the big problem of randomised controlled trials is selection bias. If this is all the people at who have the disease, generally for a randomised controlled trial, we only put in maybe 5 or 10% of all the patients because they have to fulfil certain inclusion criteria. And also, some patients don't want to participate in the research for some reason. Some people are too far away to come back to the clinic. Some people might have a very bad or serious other disease. So the big problem is that the result we get here is biased by the inclusion criteria. And therefore, as a clinician, you need to understand the inclusion criteria and how the result in the clinical trial is relevant back to the type of patients you see in your clinic. And that's really important. When you're reading the Lancet or New England Journal of Medicine article, you need to understand not only the design but the type of patients that were put in. Which is why now you have probably heard that registries, real life patients, what's called real life research, are becoming very popular. Because in a registry you can get over 90% of the patients into your registry, and you can understand the patterns of disease, the patterns of their management within your health context with least bias. It's a little bit harder to do randomisation in registries, but it's quite appealing to understand how your patients are receiving standard of care. And I'm sure that this is a very popular way to go when you're developing your research in Pakistan, is to think as a good way of get going is to get some cooperation to form registries. But even with a registry, there are some quality. You've got to have enough variables in the registry. You've got to make sure you include all your patients because you've got to reduce the selection bias. You've got to assess them early after the disease, and at scheduled intervals. You have to make sure the measurements are standardised. If you're writing your article and someone on the other side of the world has to understand your measurements, you've got to make sure that it's an international measure, not just a Pakistan measure. And then ideally, it's important that the outcomes are done by somebody who doesn't know what the patient's had, because then you get an unbiased assessment of the outcome. If the surgeon's operating on his patient and he also does the measurement of the person's health afterwards, of course the surgeon's going to make it look good and the patient's going to be more happy to tell him it's good, or maybe it's not so good. You've got to make sure that all your patients come back to the clinic. And who are the patients who don't come back to your clinic? They're the patients who don't like you, or they're the patients who are the sickest. So the patients who come back to your clinic are always the healthier. And if your registry just includes all the patients who come back for follow-up, your registry will look very good, very biased. So you have to make sure that you put a lot of effort in to make sure all your follow-up is complete, and obviously there's some issues around informed consent. So as you can see, I always say to my fellows and others, clinical research is the science of compromise. We're always compromising on trying to get the best research. We have to compromise on how much money we've got. If we got lots and lots of money, we can do more things, high quality, but we never have enough money. We're always looking at ways to, no one ever gives us everything we want. We're always looking for other things to do. How many patients we need, how much time and follow-up, how much data, how much time, how much quality oversight, and then we always also need to add in the extra time to get started. And putting all that together, as you can see, just requires a bit of thinking. Coming up with a great idea as you're driving home or on the bus, you've got to make sure you take that idea and you think about it and put together into a good plan. And then finally, writing. Well, if you want to survive in research, You have to be ready for rejection, because not all of your science can get published. And writing is different to writing a novel. When you write a novel, you can be very expansive and colourful. You can use a very romantic way to write your story and create the emotion in the reader. But when you write for science, it's brevity, it's structure. You have to put small amount of words, the minimum amount of words to communicate your science, and it needs a lot of structure. So let me summarise by telling you that to do science, you have to be a good artist, because you have to be creative. But you also got to be a good engineer or architect, because you've got to be able to have a clear thinker. But it is such a rewarding thing to do, and all artists will tell you this. To be able to create something from your own mind, to finish a product, is so satisfying. To create a scientific idea, engineer the plan, put it together, find it, write it up, and present it to the world is a very good feeling. And if you can actually get it into practice to change the way patients are managed, to develop a new technique, is very rewarding. And if you can do that in your lifetime as a doctor, you'll be so inspired to do that. And it really gives you the energy. Just remember that it comes down to the design at the beginning, and going to the statistician and asking him or her to give you the result or to make it look good is not the problem. They can never fix your poor study. You have to get it right at the end. So I have a bit of a checklist here. Good question, good rationale, background and rationale, plan it well. Is it feasible? Have you got enough time and things to do it? You have to register now for your big studies, get approvals. You have to have a good project management team. The bigger the study, the more effort for management, your statistical analysis, your writing, and if you have a large database, then the reward is that you can analyse and write papers from your database for even 10 or more years. I think this might be nearly my end. So I have another thing that I use is P's for clinical research. Obviously, clinical research requires patience. It requires you being patient. You have to be persistent. You have to plan it pretty well, and you also need to do it particularly well. So just remember the P's of clinical research. And as I said at the beginning, some of you may have the opportunity to catch the wave of clinical research and go on that journey, and maybe you can catch some other waves. It's hopefully that you don't catch a wave, start your research and you get dumped. That's always a disaster. And then finally, if you can get your research into clinical practice, is always very good. And I wish some of you every success in your research, and again thank the organising committee for this lovely opportunity to be with you today. Thank you very much. That could be a bad or a good thing. There's no question.
Most of them are, or some of them are medical students here. So do you have any advice for medical students?
I'll ask you a question. I'll ask this question. So who in the audience really would like to do research if they had the opportunity? Well, look at that. That's probably the majority, at least 2/3, to want to do research. How many people here have done research? Actually done research? Oh, right. So there's maybe 10 or so. How many people are still doing research and doing research at the moment? That's good. Excellent. Okay. So if you're doing research, you have to finish a research, you have to write it up, and ideally you need to have a publication or some thesis that you can present. So hopefully there's some words there to help you with your journey. It's hard work when you're doing the research. You wonder, why am I doing this? But it's a reward at the end. So keep going, and make sure you keep your energy, your mind and your heart strong to finish your research. And hopefully more and more people can have the opportunity to research, but it is hard work and limited opportunities.